All right, we'll discuss 3 infectious diseases of the heart today. Then we'll finish with valve disorders, and that will be your quiz next week. We'll just start with the dysrhythmias next week. That way it's continuous rather than I start half of it now and then we'll finish next week. So there are 3 infectious diseases of the heart. They can still lead to heart failure. This is referring to the structural problems of the heart because these infectious diseases cause damage to the heart valves, and therefore when valves don't open or close completely, then that will result in congestion in one or more chambers of the heart, meaning if a valve does not open or does not completely close, it will disrupt the unilateral flow of blood through the 4 heart chambers. There will be a disruption in the flow. One chamber or another chamber will have congestion, and that will lead to increased pressure of the heart, increased cardiac workload, and over time lead to heart failure. First up is the rheumatic endocarditis. Now, this one is also called rheumatic fever, meaning the cause rather is rheumatic fever. You can also call this rheumatic heart disease. Now, the cause is the same streptococcus organism that causes your strep throat, same bacteria can cause rheumatic fever. The problem here is if the patient's rheumatic, meaning the streptococcus, the strep infection is not treated or not diagnosed, therefore not treated, then it will cause the organism to go from the throat now into the bloodstream. And what do bacteria always want to eat? What do they need to live? They need, what about you? Okay, they also need oxygen and sugar, right? So sugar and oxygen, same as us, to make ATP and survive, right? So where will you get the best oxygen and the best sugar? Which part of the body? Yeah, I already said that the organism enters the bloodstream. So where will you find them? Where will you find the oxygen and the sugar? Best oxygen supply, where would you find it? Where can I stay? Because I can't stay in the lungs. I mean, it's I need space. I need somewhere to live. Where will I go? I can't live in a blood vessel because blood causes is constantly moving. Where I was set up? You know, there's no way you can live in the blood vessel. So where will I go? It's dirty there. The liver, please. There's no oxygen there. Which part of the heart? Pericardium. I'm in the blood, correct? I'm in the bloodstream. I'm circulating in the bloodstream. Where will I find the best oxygen and the best sugar supply? The left side of the heart. That's where I live. Okay, because the blood entering there, what does it contain? Oxygenated blood came fresh from the lungs, correct? So I won't want to stay on the right side because is there oxygen there? No, there's a poor oxygenated blood on the right side. So I'll go to the left side. So which valve do you think this will be affecting the most? Which valve is that? Well, it'll be the mitral valve. All right. So therefore and then the result will go more into the signs and symptoms later. But the key here is most people affected by this disorder, rheumatic endocarditis, are really the boomers, because when there were children, that's when they got these untreated strep throat. Modern medicine today, as long as you have a PCP, you have a pediatrician, you will be treated for strep because they don't play around. So whenever you have sore throat, coughing, they automatically test you for strep because it's very a simple test. You get the results in a couple minutes, right? So therefore, these people who develop rheumatic endocarditis are now the boomers now. So these are now the 65-year-old, 70-year-old people today. Do we still have rheumatic endocarditis today? Yes, but not as many as that generation. Because again, we have modern medicine today. We have new guidelines from the CDC requiring PCPs to test and treat streptococcus infections, right? So these people, though, because at that time we didn't know, so most of them did what? Nothing. Or let's say they were adults when they got it. They'll just drink vodka or whiskey, drying out the sore throat, and that's how they treat it. So they develop rheumatic endocarditis. The treatment for if you have rheumatic fever, then it'll just be antibiotics, 7 to 10 days of antibiotics. However, the if not treated, then the organism does its damage already to the heart because it will live there. It will create vegetations, which are basically small little houses that they create on the valves, and then they damage the heart valves in the process. So here are your, same as strep throat. Okay, these are the manifestations, nothing special. That's how you diagnose rheumatic fever. And of course, you need to swab the throat. And that's about it. But if the patient did develop rheumatic endocarditis, then they will develop valve problems. We'll discuss valve problems separately. Any question on rheumatic endocarditis? Very good. Let's go now to infective or infectious endocarditis. The causative organisms here go beyond streptococcus. We still have streptococcus infections. Sorry, I forgot. You were looking at this. Okay, so for infective endocarditis, this is now still caused by strep, but it can be caused by fungi also. It can be fungal, it could be viral, or it could also be other bacteria besides strep. Most common infectious organism is staph, or it will also be strep. Number one risk factor here are those with central lines or IV drug users. So in hospitalized patients, when they develop infective endocarditis, it's usually from central line. So either the nurse did not clean properly before they access the central line, or maybe it was a contaminated drug. Okay, again, who's likely to give it if the patient has a central line? The nurses either did not handle it aseptically or did not do proper central line dressing changes. Okay, so either way, who gave it to the patient? The RNs. Okay, so RNs are responsible for infective endocarditis in hospitalized patients who have central lines. Are we clear? Okay, we can blame no one else. It's really the RNs. Okay, we are the ones handling these. The doctors aren't touching them. So therefore, the fault is with the nurses. And of course, if the patients are IV drug users, then they're responsible. So here's the pathophysiology. So what happens is when you have infectious organisms, just like we described earlier in rheumatic endocarditis, so since they want to multiply and have children, grandchildren, great-grandchildren, then they will look for somewhere to live. So once you're in the bloodstream, the favorite place is in the heart valves. They go to the The mitral valve. Although they can live in any valve, but of course, if you were smart, if you're smart bacterium, where will you go? In the left side. So they usually stay in the mitral valve. Can the aortic valve also be affected? Yes, but not likely because of the pressures exposing the aortic valve. I mean, the pressures are so high, they're likely not to be able to stick there, but they can stick to the mitral valve and then make vegetations there. So these vegetations that they mentioned here are basically houses. Okay, so they make houses in the mitral valve. However, since these are describe the environment inside the heart chambers. Is it peaceful in there? No, because now those valves open and close 60 to 100 times a minute. So therefore, is it peaceful? No, it's a violent area. So can those vegetations eventually break and become emboli? Yes. So when they become emboli, now they are just like blood clots, although they are not clots. Okay, so they can travel and can they, because now they're foreign objects, they're emboli, can they clog microcirculation? Yes, they can block arteries, which will be manifested by the signs and symptoms we'll look at later. So here are your risk factors, chart 24-6. So who gets infective endocarditis? So we already mentioned people with central lines. Second, IV drug users, illicit IV drug users. And surprisingly, a person who has either repaired or unrepaired damaged valve are high risk for infective endocarditis. Also, those with implanted devices such as a pacemaker or an ICD, for instance, or you had a history of endocarditis in the past, meaning you had it once, that means do you have the risk factors? Yes. Do you have valve damage? Yes, from that previous endocarditis. So therefore, you're at higher risk to get another one. I already mentioned, unrepaired cyanotic disease, meaning the valve problems can be congenital, meaning you're born with a valve problem. Cardiac transplant, but they have valvulopathy, meaning they have some valvular anomaly. We already mentioned IV drug use. It can also be body piercings and people on hemodialysis, meaning they got contaminated, meaning they were exposed to the organism during hemodialysis. Any questions on the risk factors? All right, let's go to signs and symptoms. Okay, they don't have a chart or table, so we'll have to look at the paragraph. Is this an infection? Yes. Okay, so will the patient look sick? High fever, malaise, body aches, increased WBC, increased ESR, CRP? Yes, just like any person with a blood infection. However, there are specific manifestations exclusively found in endocarditis. They are on the next paragraph. First is there's either a new or a change in an existing murmur, meaning what is a murmur again? Murmur is because what's producing heart sounds? What's producing the lub-dub sound? How come we hear lub-dub? What's making those sounds? Mr. McNair? The contraction or the closing of the valves? Okay, when valves close, they produce the lub-dub sound. So therefore, if a valve is leaky, what sound will it produce? A murmur. Okay, so a murmur therefore is produced by a leaky valve. So instead of lub-dub, you'll hear lub, 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 because some blood leaks out as the valve shuts. Okay, meaning the valve does not shut completely. It's leaking, so therefore it produces a murmur sound. So these patients, because they have damage to the valve because of those vegetations created by the bacteria, they will have a murmur. it will eventually damage the heart valve, and therefore they either get a new murmur if they've never had a murmur before, or if they had a murmur and then further damage will cause a change in their existing murmur. So that's the first one. Other manifestations are Osler nodes. What are these nodes? They are painful nodules in the pads of the fingers or toes, meaning these are basically caused. Remember those emboli I mentioned from the vegetations that break off? So this is the result now. So they become Osler's nodes in your fingers and in your toes. You can also have Janeway's lesions. These are irregular, red, purple, painless, flat macules, also on your palms, fingers, and the soles of your feet. So you see what again? Osler's nodes and Janeway's lesions. If you have time, please search them and see what they look like on a picture. They appear as no, red streaks, round circles on your fingers, toes, and also palms and soles of your feet. These are exclusively seen in endocarditis. No other disorder has these manifestations. Finally, we also have rot spots. These are now seen in the eyes. So on eye exam by the doctor, they will see rot spots, and that will complete the picture. So they will make a diagnosis of you may have endocarditis. Now, notice I said you may have, because the only way we can confirm this is with a blood culture. So we have to draw blood culture. If it grows the organism, then that will complete the diagnosis. You have a murmur, you have Osler's nodes, Janeway lesions, rot spots, and a positive blood culture. Whatever grows in that blood culture, whether it's bacteria, fungal, or viral. Okay? It's not likely to be negative because once we have these, again, these are exclusively found in endocarditis. We don't see them in any other disorder. Then, of course, the doctor will look at his history. Okay, when they see these manifestations, they'll ask the patient, "Are you a IV drug user? Okay, do you have any implants? Do you have a pacemaker? Right? Or did this patient have a central line recently?" Okay, because that will most likely be the patient's clinical picture. So it's not very common, but the emboli can cause a stroke, although not likely. It's not very common for endocarditis to cause a stroke, but it's possible. If the embolization, the vegetative emboli are big enough to obstruct a cerebral artery, then it can possibly cause a stroke. Heart failure is a complication. We already finished complication in module 1. I mean, heart failure in module 1, so I won't repeat that. So what is the treatment again for patients with heart failure? Diuretics, beta blockers, or digoxin, and ACE inhibitors, right? Or nitroglycerin. Okay, so those same treatment. And then sodium restriction, fluid restriction, weigh them daily. Remember? MODS. Okay, so we won't repeat that. Diagnostic tests again, we will go with the, so here's heart failure. I already mentioned we will do blood cultures. Now, as far as evaluating, remember, this condition will cause a heart valve damage, correct? So the doctor will have to order an echo. Echocardiogram is basically an ultrasound of the heart. So we'll look at the heart chambers. We'll look at the pictures inside the heart to see how are the valves looking? Are they damaged or not? If they're damaged, then they'll decide whether or not the patient will have repair or replacement of that valve. Meaning if it's beyond repair, we have to replace it, because otherwise the patient will be in permanent heart failure. The first part here for the diagnostic test, again, no different from any other patient who has a blood infection. They will have elevated WBC, elevated ESR, elevated CRP. The best type of echocardiogram would be a TEE. This stands for a regular echocardiogram is called a TTE, meaning transthoracic. We just put the probe over the chest. However, a TEE would give you the best picture. TEE stands for transesophageal echocardiogram, meaning instead of putting the probe here over your chest wall, we would put the probe into your throat and then look at the heart from the esophagus. So it's an endoscopic procedure. That of course, is the best picture compared to a TTE. Yes, just like any other endoscopic procedure. So prevention, one of course is who are at risk again for these. What were the first two mentioned in the paragraph? They are the patients with central lines and patients who are IV drug users. Now, as far as prevention, since remember in here on the risk factors, who are at risk again for endocarditis? People with, look at the fourth bullet. Okay, so those with valve disorders, correct? Or the first bullet, prostatic heart valves or valves that are unrepaired yet. So therefore, since they are at risk for endocarditis forever, now before they go for certain procedures, especially oral or dental procedures, they have to be placed on prophylactic antibiotic therapy. Describe the health of your mouth. Is the mouth the cleanest part of your body? It's the dirtiest. It's actually dirtier than your rectum, okay? Because we have more organisms in our mouth compared to the rectum. Rectum only has E. coli. Our mouth has multiple organisms living in it. So therefore, plus what do you notice whenever you get your cleaning, let's say your dental hygienist works, what always happens to your gums? It bleed, right? Okay, so therefore, when you have wounds now, you bleed, your mouth is dirty, you have organisms there. So can they enter the bloodstream now? Easily or very hard? Very easy to enter. So therefore, since these patients are at risk for endocarditis, so we put them on prophylactic antibiotics, okay, before any dental work or any oral surgery. That's the only recommendation though by the American Heart Association. Used to be they included any invasive procedure like a bronchoscopy or colonoscopy. Now they say no, just oral and dental procedures. Okay, that's the only recommendation for prophylactic antibiotics. So patients at risk should practice good oral hygiene. Again, very important. If there is any invasive procedure done in the mouth, what must they take? Prophylactic antibiotics. Management. Because this is an infection, so how do we treat it? Antibiotics. Unlike in rheumatic endocarditis though, wherein it was oral, where we put the patient on oral antibiotics for 7 to 10 days, regular penicillin, unless they're allergic to penicillin, then we'll use something else. Here, this requires long-term IV antibiotic therapy because this is a serious infection. Patient could develop sepsis and die. Now we have to make sure we treat it. This is aggressively treated with 2 to 6 weeks of IV antibiotic therapy. Now, because this involves long-term antibiotic therapy, what is our IV access? They will be given a central line if they didn't have one already. All right. Now, what was one of the risk factors again that we started with? Patients with central lines. So therefore, we're treating this patient via a method that puts them at even a higher risk for another endocarditis. So therefore, what's your priority in these patients? Aseptic technique, okay, with handling the central line and also dressing changes, okay? Now, the setting here in a ideal world is the patient won't stay in the hospital. We will have to send the patient either home with home health care, meaning the nurses will go to the house access their central lines and give them the antibiotics daily, or they go to a rehab facility and finish their IV antibiotics there, because they can't sit in the hospital just simply for IV antibiotics. Okay, the insurance company won't pay that. The insurance company will say, "Is that all he's staying there for? Send him somewhere else." Right? Now, the problem with some facilities is, let's say it's a city hospital. Now, resources are limited. And most of these patients, who are these again? Who are these patients? IV drug users. So therefore, do they likely have insurance? We have limited Medicaid or no pro bono patient beds in facilities. They're required, a facility, let's say long-term care or rehab facility, only has a limited number of beds for Medicaid. Because they're trying to run a business. So therefore, they would only limit how many Medicaid beds they will have, because these patients are not long-term patients. These are short-term. Okay, so they go to a rehab floor. And the more lucrative business in a rehab are those that require actual rehab, knee, um, hip surgeries, those kind of things, no heart surgery patients. Those are the ideal clients of the rehab facility. Now, these patients, therefore, are not really very, attractive to. So city hospitals will have problems placing them. Okay, and can you trust them to go home with a central line? They have IV drug use history? No, because otherwise they'll party, right? Oh, here, guys, I have a central line, right? So therefore, you will see in city hospitals that these patients will stay there for the entire 6 weeks of IV antibiotics. Okay, so they're basically on vacation, right?
Reason for the 26-week treatment because the heart is so heavily protected, it's hard to medication.
Well, not really that. We want to really eradicate this organism for sure. And the only way to guarantee that is aggressive IV antibiotic therapy. Is we can't take a chance. This is the heart that's infected. Right? So it's really, a high stakes treatment involved. So we want to make sure we aggressively treat it. Now, of course, during the therapy, we have to draw weekly labs. We have to see if the treatment is working. We can't wait till the end of the 6th week. So every week we have to monitor lab work. All right. And then how did we make a diagnosis again? We drew what? Blood cultures, correct? At the start. So how do we know it worked? We'll draw blood cultures again at the end. Okay. So if the blood cultures grow negative, then okay, you're free to go. See you next time. Surgical management. This will be included because remember there's valve damage, correct? So therefore, if there's a damage which can be repaired, we call that valvuloplasty if it's repair. And then if not, if it's beyond repair, then we'll have to replace it. Management. The patient does have some pain, so therefore antibiotics or whichever is the organism, antifungal or antiviral. For the fever, of course, we treat that with Tylenol or NSAIDs. If the patient did develop heart failure, then they'll be treated for heart failure. Same therapy again as we learned in Module 1. And as we already mentioned, meticulous central line care. So management when meticulous hygiene, aseptic technique when accessing the central line and also when changing the dressings. Ideally, again, home health care should be the setting for this patient. In some cases, so let's say this is a patient, with a decent living situation. There is a supportive family. Because if that is the case, because we have to report it to Medicare or to the insurance company. So if there is a teachable person in the family, we teach and train that person. Okay, we teach them how to access the central line, give antibiotics, flush before and after, and put caps. Okay, we can train the family member. In very rare cases, let's say the patient has a medical background, let's say it's an RN that's affected, then they can do their own antibiotic. What we do is just give them an extension so that they can use both hands to access the central line, right? But of course, the dressing change still has to be done by the RN. So RN has to visit them once a week to change the dressing, okay? And to draw labs or whatever. The surgery will be done on a separate page, so I'll go to that separately. Any question on infective endocarditis?
Yeah.
What's the question?
If the patient had the clinical manifestation of the pneumonia, estomod, and the other two, and the blood test is negative.
Again, that's almost impossible for it to be negative. Yeah, because if you have those, then that's endocarditis. But again, we can't make a
Final decision
diagnosis because we still have to identify what organism anyway, because we have to decide on which antibiotic to use. So we still need the blood culture. We can't just use any antibiotic. Okay, so there's something called ID and sensitivity, meaning yeah, in 24 hours we can identify the organism, but then it takes a while longer, another 24 hours to identify sensitivity, meaning we will expose that organism to a number of antibiotics, and then the doctor will choose which antibiotic was that organism sensitive to. Okay, and then they'll start with that antibiotic. But most cases they already know. I mean, based on the patient's profile, they already know, it's likely staph, or that's likely strep. Then they'll start the antibiotics without waiting for the blood culture results. Okay. All right, next problem is myocarditis. This is basically, so endocarditis was the innermost lining of the heart, right? So now this is now the muscle itself. So same reason, same risk factors. Now it can be caused by bacteria, fungal, or viral infection. Now, since this is involving the heart muscle itself, can this cause heart failure? Will this also cause some elevated troponin, like a heart attack? Yes, because this is the muscle itself. So therefore, the manifestation, if you look at it, it's really manifestations of heart failure, okay? Nothing specific to myocarditis. And diagnostic findings, same. We test blood culture. Is this caused by bacteria, fungal, or viral in nature? And management, same. If once we identify the organism, we treat it with antibiotics. Simple as that, or antiviral or antifungal. Any question? But since the patient develops heart failure, do we also treat the patient for heart failure? Yes. That's it. Let's go now to the third, which is pericarditis. Yeah, that's it for Mayo. Okay, so pericarditis, this is now the outside lining. This is now the sac surrounding the heart. If you compare, if you want to imagine, this is like if the heart was the testicles, the pericardium would be the scrotum. All right, so this is now the sac around the heart. Because as you know, any moving part, any moving organ in the body has to have lubrication, correct? Meaning the muscles are moving, so they have the fascia, right? And there's a little fluid there. So our heart is also moving. We have the pericardium. The pleura are moving, meaning the lungs are moving. So we have the pleura. Our joints are moving, so we have the synovium. Okay, so the brain moves, so we have the meninges, okay, etc. So this is now the infection or inflammation of the sac surrounding the heart. Now, how did this happen? There are 4 frequent causes here. Let's look at the pathophysiology. You know what? Yeah, pathophysiology. So there are 4 conditions, 4 instances where this can occur. Number one is infectious, just like endocarditis, just like myocarditis. Could be an infectious cause. Again, bacteria, fungi, and viruses. Or it could also be inflammatory. Number one cause, if it's inflammatory, is lupus. You heard of lupus? No, same lupus that causes lupus nephritis, kidney damage. That lupus, because lupus is a systemic connective tissue disorder. The pericardium is a connective tissue. So this can be caused by lupus exacerbation. Third, it can also be caused by a heart attack, meaning after part of your myocardium died because of a heart attack, there's inflammation around the dead area, which can cause pericarditis. The fourth cause is if it's also a heart attack, but the pericarditis did not occur within 24 hours of the heart attack, meaning it occurred weeks later, 2 weeks or longer after the heart attack. We call that Dressler syndrome. Clear? Okay, so those are the 4 frequent causes. There are other causes, but most of the time, those are the 4 frequent causes. Heart attack, 2 weeks after a heart attack, lupus, or infectious cause. Now, the problem with this is, will the heart stop beating if the sac around it is inflamed?
No.
It has no choice. The heart has to continue to beat. So let's put it as, looks like a party girl here. Christina. So let's say Christina is going to a party tomorrow night, Friday. She just bought new shoes, okay, 6-inch heels, okay, to go along with a nice dress. So she and Sophia are going to, clubbing. They already got tickets and they know the bouncer, okay, they're gonna be let in for sure, okay. And then she go dancing, she's on the ledge, so, but her shoes are new, so she didn't get to break them in. So they didn't really have, loosen yet. So what will she have in the morning? A blister in her heels. Imagine the same scenario here. The heart will continue to beat. The pericardium is already inflamed. Continues to beat like this against that inflamed pericardium. So what will form there as well? Kind of like a blister. So there will be increased fluid, because the fluid there is supposed to be only between 2 and 5 ml, just for lubrication. But now, because of the constant rubbing, that fluid could potentially increase. If it reaches 50 ml or more, we call that condition cardiac tamponade. This is life-threatening, okay? Because imagine if your heart is surrounded by water. You have 2 lungs here, and then the heart in the middle, and then it's now surrounded with lots of fluid. That fluid could also be blood, because it can bleed sometimes. So what will happen to the venous return inside the heart? Because it's like the space will not increase. The space is the same, right? So you have a right lung, left lung. The mediastinum is all the space your heart has. It's supposed to occupy the entire mediastinum, but now it has to share that space with lots of fluid inside the pericardium. So can it do its job effectively? No. So it's now restricted, correct? So therefore, what happens to cardiac output? What happens to jugular veins? Distended. And what will happen to blood pressure? What will happen to heart sounds? If I listen to this patient's heart sounds. Well, it won't be crackles because there's no air going in there. So what will you hear? The heart is now surrounded with fluid. So what will the heart sound like? Muffled. Okay, so like or it'll sound very far. Okay, sound very distant. The number one complication by this, and that is again life-threatening. So we'll discuss management of that later. manifestations will be, will there be pain? Yes, there will be chest pain. Patient will complain of severe chest pain. Pleuritic in nature, meaning when they are, especially when they're laying down or standing like this, it will be very painful. With every heartbeat is very painful because that is literally the heart beating against a really inflamed pericardium. The only position that will relieve the pain is if they lean forward, sit up and lean forward. That provides some relief. But of course, can you sleep like that? No. So we have to treat that pain, correct? And when you listen, besides the, but by the way, sorry, don't confuse this, okay? So the muffled heart sounds, hypotension, and the jugular vein distension is not a manifestation of pericarditis. What were they a manifestation of? The cardiac tamponade. Are we clear? Now, is cardiac tamponade a manifestation of pericarditis? What does that say there? Is it a manifestation or is it a complication? This is a complication. Okay. Is this a life-threatening complication?
Yeah.
Yes, this is a life-threatening complication. How about these though? The chest pain. Are these life-threatening? No. No, they are not. So only the cardiac tamponade is life-threatening. This one is very uncomfortable, but is it life-threatening? They are not. Are we clear? So pericarditis itself, is it life-threatening? No. What will be life-threatening? Cardiac tamponade will be life-threatening. Okay. But are they at risk for cardiac tamponade? Yes, every pericarditis patient must be monitored for cardiac tamponade. That's why we emphasize, what were those 3 signs again of cardiac tamponade? Hypotension. Again, don't jumble them together. Those are separate. Chest pain here is for pericarditis only. Are we clear? And then what will you hear? A creaky or scratchy friction rub. This is again for pericarditis. This is not cardiac tamponade. Okay, these are all for pericarditis. And because it's an inflammation condition, so there will be elevated WBC, elevated ESR, elevated CRP, just like endocarditis. Can this cause heart failure? Yes. See, we already discussed the causes. So it either infectious or I mentioned the lupus, it's there, right there. And then we have the heart attack after right here. So it could also be from heart attack or 2 weeks after a heart attack. To diagnose, we also need an echo. Now the echo will show, of course, the inflamed pericardium and to see whether or not there is impending cardiac tamponade. Management, well, it will depend. What is the cause of the patient's pericarditis, right? So therefore, if it's lupus, what will be involved in the treatment? Because lupus is autoimmune, inflammatory. What will be involved? Steroids will be involved. If it's bacterial, fungal, or viral. Okay, antibiotics, antifungal, or viral. If it's a heart attack, we treat the heart attack. All right, are we clear? All right. Yeah. Because the management for pericarditis is really symptomatic. The pericarditis itself, you only treat because what's the patient's #1 complaint? Chest pain. So therefore, what do you give? I mean, pain. What do you give? No, this is inflammatory type of pain. It's not caused by... So these patients will not, they will respond to opioids, but is opioids appropriate here? No, because this is inflammatory. So therefore, can they benefit from NSAIDs? Yes. So here are the treatment options. So we've got aspirin because this patient can have heart failure. Indomethacin is a type of NSAID or ibuprofen. We have steroids only. Which patients can get steroids? If it's caused by lupus. Because can you give steroids if it's bacterial cause? No, because that will, right, make the infection worse. Colchicine will also help. Colchicine is normally given for gout, but patients respond well to colchicine for this type of chest pain. Now, here's the management. If the patient does have cardiac tamponade, patient will have to have emergency pericardiocentesis. Now, what is this procedure? This is the insertion of an 8-inch 14 to 16 gauge needle. Can you imagine that? 8 inches long and how big? 14, 16 gauge. That's a huge needle. We're going to have to insert that through your chest wall and then puncture the pericardium to drain the fluid. Now, how do we accomplish that? How does the doctor accomplish that? We need ultrasound or fluoroscopy. The doctor needs to see where is my needle, right? He needs to see the position of the needle because can he just jab this? No, he'll puncture the heart. Okay, so we need to see where we're going. So either ultrasound or fluoroscopy. In some cases, so let's say it's not cardiac tamponade. Let's say it's pericardial effusion, which can be caused by cancer. Let's say you have some lymphoma in growing, you have a tumor in your thoracic cavity. If that's the case right here, if it's neoplastic disease, neoplastic means it's cancer. What they'll do is create a pericardial window. Because the problem is, if it's cancer in nature causing the effusion, meaning the fluid collection in the pericardium, it's likely to reoccur. So are we going to subject this patient to repeated needle sticks of that 8-inch 14 gauge needle? No. So it's likely to reoccur. We have to create a window. A window is simply they'll cut a small opening on the pericardium. So instead of the fluid accumulating in the pericardium, what will it do? Just come out of that window and then go into the peritoneum, okay, where it won't cause problems because which one will be bigger, the peritoneum or the pericardium? The peritoneum is large. Look at mine, right? So I have plenty of room here, meaning there's not enough time for your body will eventually reabsorb all this fluid, but it won't reabsorb in the pericardium because the heart has a very small space. We have plenty of space in the peritoneum. So if we let it drain there, it will eventually be reabsorbed in the capillaries. Are we clear?
Yeah.
All right. All right, I'll quickly go to the valves. And let's just keep it simple. Okay, valvular disorders. So there are two sets of valvular disorders, either stenosis or regurgitation. So either the valve does not open completely or the valve does not completely shut. Whichever is the cause, let's say endocarditis, for instance, which is the most common, or it could be congenital, you're born with it. Regardless, what will the patient develop if you have valve disorders? Heart failure. It will cause heart failure or dysrhythmias as well. It can cause atrial flutter or atrial fibrillation. Okay. So here are the pictures. So the patient's valve either does not open completely. These are normal valves. Okay, so that's what your valves were supposed to be look like. But then when they don't open or close completely, then that will be abnormally shaped. Here's proof that the patient's manifestations are those of heart failure. Because there are many types of heart valves. Look at these manifestations. What do they remind you of? What are they manifestations of? Heart failure, right? These are heart failure manifestations. Now, the difference will be based on where is this valve located. So if it's the mitral valve, what type of heart failure will the patient manifest? Left side or right side? Left side, because where is the mitral valve? It's on the left side. Make sense? And then when we say it's the tricuspid valve, what type of manifestations will the patient have? Right side heart failure. Simple as that. Let's go now to repair. Page 771. So this is repair, valvuloplasty. What did we say again? After this procedure, what will the patient require? Because now they have a repaired heart valve. So what are they at risk for? Specify. What did we talk about on the first? Endocarditis, right? Okay, so therefore, what will we teach them to do forever? To take what? Before? Okay, so prophylactic antibiotics before oral or dental procedures, right? For nursing care, it's not really different than any other surgery. However, I know this still says open heart surgery. However, today, they can do this in the cath lab now. There's a procedure called TAVR, T-A-V-R, which changed the prognosis altogether for high-risk patients. Let's say you're 80 years old and you have a heart valve that needs to be replaced or repaired. Used to be, it was open heart surgery. Now, can you do open heart surgery on an 80-year-old patient? No. Very poor candidate, right? So on the olden days, we would just tell them, sir, you're high risk for surgery. We cannot change or repair your heart valve. Okay, sorry. Nowadays, because it's done in the cath lab through an artery, either femoral or radial artery, they can repair and change heart valves now through that procedure. So it changed the game altogether. Okay, so now regardless of the age, patients' heart valves can be repaired or replaced. Now let's go to replacement. So if it can't be replaced, now we have, it can't be repaired. Now we have to replace. We'll focus on our nursing care. So what do we do? What do we teach the patient after replacement? Teaching will be based on what valve was used to replace it. Now, there are two types of valves we can use. It's either mechanical, made of steel or titanium, or it can be biologic, coming from another human being, a cadaver usually, or coming from a cow or a pig, because a cow and pig's heart is the same size as ours, so we can use either biologic, again, from cadaver, dead person, a living pig, or a living cow. Well, I shouldn't say that because we had to kill the cow and the pig, right? To get the, so never mind. So they're all dead. So here's the TAVR I mentioned earlier. So TAVR is basically revolutionized valve repair and valve surgery. Okay, amazing development. So for the patients who receives a mechanical valve, we have to use, and these are the pictures. Okay, so these are mechanical valves. Okay, they'll last forever. The decision as to which valve will be used, whether mechanical or biologic, which one will last longer? Compare a human valve versus a titanium. Yeah, this patient will, well, you'll be, let me put it this way, you'll be dust and everything. This titanium will still be titanium.
It won't create any poison.
Well, that's why we put it in there. Yeah, it won't. Okay. Just like, you know, knees, hips, those are all steel or titanium. Okay. All right. So if the patient has a mechanical valve, now because it's foreign, will it cause or attract a blood clot? Yes. So therefore, what do we need to put the patient on forever? An anticoagulant. We'll discuss anticoagulant therapy and how to use it, how to manage it another time because it's a whole class. So that's what we'll require for mechanical valve recipients. They have to be placed on anticoagulants. Sadly, the only anticoagulant indicated here is warfarin. We cannot use any other anticoagulant. It's exclusively warfarin. The other, why? Well, the drug company said so. They ran tests. They put mechanical valve recipients on other anticoagulants other than warfarin. They developed blood clots. So they did not work. Only warfarin had a high protection from clotting. Okay. Tissue valves, or also called biologic valves, since these are like living tissue, these are living tissue. So are they likely to attract blood clots? No. So it tells you right here, tissue valves are less likely than mechanical valves to generate thromboemboli. So therefore, thank you for reading, Mr. Soler. Okay, long-term anticoagulant is not required. Are we clear?
Yeah.
Okay, so this is very important teaching. So this is done by the doctor before the surgery even happens. So they'll discuss the options. So who's likely to receive a mechanical valve? A younger or an older patient? Mechanical valve. Because how long do you expect the young person to live? Longer. So what will fit them better? A mechanical, because a biologic will probably last 10. You're lucky if it lasts 20 years. Then we have to replace it. Let's say it's a 40-year-old patient. They have a long life to go. So they'll likely benefit from a mechanical valve. However, the sad part is they have to be on anticoagulants forever. So they weigh it. So the patient, of course, can choose, okay, I don't want to be on anticoagulants. I'll take the biologic. But they'll be told, okay, we may have to change that eventually. Okay, we have to replace that again in 10 or 20 years. Any questions? That's it for today. Please put your